have our next speaker, Dr. Gaurav Luthra. Thanks, Dr. Gaurav, for being there after such a busy schedule. He's going to talk about some of the worst cases of brown cataract, black cataracts, white cataracts, and on a femto platform. How good is it? How bad is it? Over to you, Gaurav. Thanks so much.
Thanks a lot, Dr. Himanshu. Good morning, everyone. And I'm sure almost everything is covered. I'll try to show you one or two cases, and we are very short on time, so I'll just stick to some hard brown cataracts. I think femtosecond laser has become an amazing tool. I like to use it for all the hard brown cataracts, and unlike the intumescent and the white cataracts where the OCT will not penetrate and check out the posterior capsule, and also unlike the very opaque kind of cataracts, but in the brown cataracts and the black cataracts, usually the OCT as well as the laser will penetrate and give you good cleavage planes. It also gives you a good size predictable rhexis. Usually these hard brown cataracts will have some fibrotic changes in the capsule as well, so it becomes quite useful. So this is where we are planning the laser delivery, and the planning also can be a little different from your usual femtosecond lasers. So I have switched from the 6-quadrant crack to the 8-quadrant crack. And let me just take you back and show you what all you could do. So in between, for a few years, we were doing these octants and this, along with that, getting these small cuboids. But this used to really use a lot of energy and could be sometimes endothelial unfriendly. And also it would, sometimes leave behind these small cuboids. So if you look over here, you could actually do a 4-quadrant crack and then have small, kind of a grid kind of a pattern, but we no longer like to do that. But yes, if you have a very hard cataract, a 6 or 8 quadrants done correctly with the correct energies will do well. So here I've switched to that, and then I'm changing the spot separations and the, to make sure that I'm getting a better cut and the energy as well. I've also enlarged my rhexis size to about 5.2, and then I'm going to just check if the LRI is also going to correct, just like Rohan was talking about. There's about 0.75 astigmatism, which I'm correcting with this single LRI. And then firing the laser. So you can go for a slightly bigger rhexis size, and you can, in these very hard cataracts where there's going to be lateral separation and you want a bigger rhexis size, otherwise normally I would do a 5 millimeters, but here I chose to do a 5.2. And once you have that in place, this is the cataract that we were operating. So these cleavage planes will be pretty good. Your rhexis will be quite, unlike what many people would like to think, that these rhexis are not very strong. They are very strong, and I'm yet to see patients where I've lost the rhexis in femto because I was doing some maneuvers for the nucleus. So they are equally as comfortable as a manual rhexis. So once your capsule is out, then you have to deal with these some of these really hard brown cataracts. And frankly, these cleavage planes work quite well because you can embed and then crack along these planes. And the phaco energy used is much less, and your endothelium protection is much better. So you will have a much, much quieter, cleaner post-op clear cornea. So had it not been for the cost of the femtosecond laser and the running cost and all that goes with it, this would be a great tool, in most clinics, but the prohibitive cost and everything that goes with it, as I said, the CMCs and the AMCs. So you can see that separating them becomes so much easier. I'm not having to apply that much force. Even cracking the posterior plate becomes easy because there's very little left at the posterior plate to crack. And lateral separation is much, much easier because you already have the cleavage planes. Of course, I mean, if somebody had to say whether you can do these hard cataracts without the femtosecond laser, you can, but if there's a better way to do it, then why not? So I'm sure many surgeons would switch to an SICS. If I can do a femto-assisted surgery, I would rather do that. I'm more comfortable with a closed chamber fluidics. Of course, SICS would be a great technique as well when there's no access to maybe a high quality phaco machine or to a laser assisted surgery. So you can see that once it becomes almost like a routine case because your cracks are all there. And of course, you could use the softening if you would like to use it. Some surgeons like to use the softening feature. I don't, because it tends to sometimes leave these very small nucleus fragments somewhere in the bag or in the sulcus, and they will cause persistent inflammation. So I stopped using that, the grid pattern, which is the softening pattern. So nothing much to show here, and let me take you to the end of this surgery, and that's the hard cataract gone, and of course the rest of it is routine. Let's see if there was another patient I thought I would like to show you here, because I think we are already out of time for the session. So this was a patient with a, I'm sorry, there's another one that I wanted to show you. Okay. So this was a smallish pupil, and there are maneuvers that you can do to give you a slightly better pupil size. Some people would like to use a B-hex ring. Some people would like to inject phenocaine before they did the laser. If I'm getting a 4 millimeter excess, I will usually not do anything. So here we got a 4 millimeter excess, and then I've put a Malugins ring, and I've also done the softening. So the central part of the hardest part of the brown cataract is already cleaved. And although the periphery is not, but that's not the hardest part of the cataract, so it becomes easier to deal with it at this point. So you can see that even in a slightly smallish pupil, and here I'm using a Malugins ring, and this cataract is chopping much more easier because I already have the cracks in place in the central hardest part of the nucleus. Especially there will be some patients who have slightly compromised endothelium, and you are dealing with a very hard brown cataract, so you'll have two choices. Either you go with an SICS under viscoat cover, or you can do a femto-assisted if you want to minimize the endothelial damages, because you will be able to have much less effective echo time for those patients as well. So essentially, some of these patients will also have pseudoexfoliation, they will have capsular changes, and all those can be much better tackled. I think Dr. Ramamurthy was showing how to deal with rhexis in those fibrotic capsules. And then also for intumescent cataracts, I would have this as my first choice. The risk of the FLACS sign, of the Argentinian FLACS sign and runaway rhexis is much less in a closed chamber. And femtosecond laser is, even if it doesn't complete the rhexis, there will be a good imprint on the capsule at some points. All you'll need to do is just complete it. So here we've been able to complete it, and with that I think I would like to stop. And this is another coloboma with a hard brown cataract, but I'm sure many of these things have already been covered. So I would just like to summarize and say that for me, femtosecond laser has been a great tool for all the complex eyes. Post-RK, it's my procedure of choice. Posterior polars, intumescents, pseudo-exfoliation, very small eyes, very shallow chambers, hard brown cataracts. So I'm sure all that has been covered in this course today. Thank you.
So one question I have, what's your reduction in terms of percentage if we see in the CDE using the FLACS and not using the FLACS in like hard brown cataracts?
So we've been kind of, okay, specifically for hard brown, see what's happened is that over time we've now made changes. The catalyst and most of the other lasers, they now, number of passes that they make, and the energy and the spot separation that we use, and also the central sparing, nomogram which came in. So I don't like to have very long procedures with the femtosecond laser now. Previously we used to do like 90 seconds to do the nucleus. Now my nucleus is done in 30 seconds or something. So that transport delivers much less energy, it does the job very effectively. And I think the endothelium, I would again, as I said, procedure of choice under viscoat cover, I would always do a femtosecond assisted cataract surgery for patients with compromised endothelium.
And what about using like a flower petal technique in cases like this in a femtosecond? Have you done that? Like once you've got the
flower
fragmentation?
petal happens on its own for me sometimes. I will have once I, kind of cleave the 6 quadrants or whatever, it separates out that endonucleus on its own, and you will just kind of, ease it out, and you have more space and a crater created, and then you do a lateral separation of the posterior plates.
As you mentioned, the hardness is actually right in the core only.
Right.
The periphery is not that hard in
Absolutely,
anyway.
yes.
So we've seen all possible cases: posterior polar, hard cataract, brown cataract, rhexis, astigmatism. A question to the panel: if you have to get your cataract operated, would you even blink an eye? Would you do it with a femto? Yes or no? Everybody?
Definitely.
Yes. Gaurav, we need you on the stage. Any questions from the audience?
So for the small peoples, I tried the BX ring before starting the procedure. That is, gives a desired size of the rhexis. Need not worry about these myotic peoples. So only thing is inject the visco without bubbles. That is one thing. What is the lowest parameter of the ACA to prevent the damage of the endothelium?
Damage to the endothelium, anterior chamber depth doesn't matter. In fact, the lesser the depth, the better it is for you, because your rhexis is definitely going to be better. In a dirty big white cataract or a big brown cataract where the chamber is terribly shallow, the endothelium is not good, there is an arcus, I think it doesn't matter one bit on the endothelium whatsoever.
But this says, this definitely the grid pattern will reduce the phaco power. We compared direct thing with the grid. Grid definitely reduces the phaco power.
Yes, no question about it. In any and every case, the phaco power effectively goes down 50-60%. You saw his lovely, yeah, go ahead, Gaurav.
Okay, okay. You're next, we know that. You'll be first next time. We'll be behind you.
You want to minimize the laser time, so even the grid pattern can have compromises of the endothelium because of, too much energy being delivered into the eye. So it's a balance. You have to just strike a balance.
One second, take a picture. Yeah, thanks everyone.